Sollis. Better insights for better outcomes. This session was recorded live at our Advances in Population Health Management workshop in London, November 2018.
So our two good friends of ours from GE Healthcare. When Graham and I set up Sollis all those years ago, 25 as I say now, a view that we took very early on, and it goes back to I think a comment that Steve made earlier, was this is a big elephant, don't try and eat it all at once. We get that in spades. Neither can we not eat it all at once. On occasion we can't all do it alone. And I'd like to think that Sollis has a history of collaborating with other partners where they can add value and where simply we don't have the skill set. We're not proud to say that, and we'll work with anybody who can help us move this needle, as I spoke to earlier. I think that Johns Hopkins is a good example of that, the collaboration of 10 years, a more recent collaboration with our good friend Steve here, who gave us insights into primary care home and how could we work with him to make that matrix come alive. So we're doing that with Steve. And GE Healthcare, another example of some big brainy people who bring added value to the tool set and the consultancy skills that Sollis can offer. So if I may invite Pat Nichols to the stage. He's a specialist BI person with 25 years experience in the industry, now working with GE Healthcare. And Sarah, I do apologise in advance, I did warn you I'm going to get this wrong. Ouanhnon. Is that close?
Close.
All right. My degree was not in languages, it was in politics, but what good that's done me. But Sarah Ouanhnon, and they're both going to talk about the work that we've done together, led by GE in Medway, Kent.
We'll give some floor time to Graham as well. So we always like to start with a purpose, objective and outcomes, largely because it has a juvenile acronym. So just want to go through essentially what our take on population health as the basis for enabling the delivery of transformational change is, and then really bring that to life through two key client case studies, one being Medway, which is more recent and at the start of a journey, and then the next being Wandsworth, which is a little older but actually further through the journey of implementation, answering that key question around how you actually measure what has happened. So I think some of this has already been covered by Nigel at the start, so I'm not going to spend too much time on it, other than the really key standout for me is that actually if we don't do anything about where we are today and how things are going, we need another 80 hospitals to be built within the next 15 years. There isn't space to do that, there isn't money to do that, and clearly there isn't will to do that. So that's kind of the thing that really brings it to life for me as to why something needs to change. So coming on to our take on population health management, then I am part of GE, so the bottom of the circle is very much GE's, bigger GE's life, bread and butter, the management of operational processes with operational systems. This is decision making in the here and now about the immediate and the communication of very detailed operational and clinical information. As you move towards the centre of the circle, we are moving more into operational management and commissioning land. Above the line, we are in the realm of the individual. So the dark green is very much the space that Sollis operate in, the population health information, which essentially is bringing together a lot of what would be considered operational data under the line and bringing it together around the patient to actually get the longitudinal record. Outside of that, there's also very interesting things happening around the individual personal care data sitting on iPhones, etc. Things like gait analysis, predicting falls, things like triggering people to remind them to pick up prescriptions when they're walking past a pharmacy, all these kind of really amazing Big Brother stuff. The key for me is that actually what we're going to describe today really works because it sits over the systems and the informations that are actually used by clinicians to manage their patients. And so that clinical credibility barrier doesn't exist because it's already overcome. So we're change managers inveterately, so I can't possibly get through this presentation without putting up a discover, redesign, implement, sustain and improve journey. Really the purpose of this is to actually land the case studies that we're about to go through. Medway is very much at the beginning of the journey, very much around the discovery and actually precipitating change and the shared narrative for change. The Wandsworth case study is much further through. We met them at the point of being some distance into implementation. Hopefully our next steps in Medway are around redesign, but fundamentally we have got a presentation that follows this chronologically. In reality, the power of what we're presenting is that we start at the end with the outcomes and work backwards to what needs to happen to deliver them.
So we wanted to share with you our experience in Medway because it was a really interesting challenge for us. To give you some of the background, basically we had a system where the relationship between the trust and the CCG was really fractured, like complicated situation. The trust has just been out of special measures just 1 year before, and the trust deficit was around 18%. But what was changing and where we saw an opportunity is that suddenly the stakeholders didn't see this 18% deficit just as a trust problem. Suddenly it was a system problem, and that really was a good starting point for us to help them work as a system. The challenge there was really to help them establish a common view to start with. Just one version of the truth, and then looking forward, agreeing on what would be our ideal future state, where do we need to focus, and what do we need to do to get there. So our approach really, we use classical tools, interviews, modeling, 10-year projection. We used Clarity with Sollis, did population health analysis, used the Johns Hopkins ECGs, and developed a better future scenario. Really what's to understand here is that we try to triangulate our stakeholder views, and it was very important for us to engage with the whole system, so with stakeholders from every organization, with what operational data gives us, and also what clinical data gives us. And that's where the ACGs really come into play. Graham, do you want to...
Oh gosh, yes. Somebody said there had to be a technical diagram and I had to talk to it. So I'm not going to come around the corner, but this is sort of a bit like what goes on under the hood. But the main thing about it is that lots of data can be ingested, and the really interesting thing for this assignment was that we weren't sourcing the data. All the data that we analysed came from the Kent integrated data set, and there are other various joined up data sets that we've been working with since then. So we didn't have to source the data, we just had to transform what the Kent people already had. I always get the blame for describing the Johns Hopkins tool like that because it's basically a radio that I stole from a Visio slide, but it's not a radio. And then there's various analytics that come out of that. What was unique in this assignment was there was a huge delivery of analysed data that went through into additional analytical tools that GE had. So it was a two-handed thing whereby we would analyse some of the analysis, do some of the analysis, and then pass it through to GE to add value as well.
Do you want to get us to the different stage?
Oh, yeah, okay. So this is the stages. I'll come on to this. So having pulled together that linked patient data, there was a lot of cleansing. Every time you come to a different linked data set, you'll find something new about it that you didn't expect to see. And there are certain compromises you have to make. Then we push the data through our own analyses and Johns Hopkins analyses. And I think one of the things that we're very aware of is that Johns Hopkins isn't just a risk tool. It contains a whole range of other capabilities, and in particular, one of the things we did was use some of the actuarial capabilities of the Johns Hopkins tool. So you can build cohorts of common need. You're going to pick me up on this, aren't you? Get it wrong, Alan.
James.
Okay. And you can use those cohorts of common need to compare between different care economies, and that was part of what we tried to do for this assignment. And that's where we got to the benchmarking, where we built a benchmark from other care economies that were similar to Medway, and then said, okay, so that how is Medway performing compared with similar economies. And that was really interesting because that gave us a lot of insights into where they could be given comorbidities, the deprivation patterns and so on and so forth. And that was a good starting place for further analysis, I think. And we tied that back to individual practices, and also groups of practices, and also to some of the geography of the area.
So we've been a bit mean because we've left the technical bit to Graham, and now I'm going to give you the insights and output. So I'm taking all the fun stuff. So this was really our eye-opening output. So I know you can't see very well, but what's the takeaway message from this is the bars are Medway situation, and the dotted lines are risk-adjusted curves. So what we've seen in Medway is that actually people have higher needs earlier. So where we usually focus on our 65 plus population, actually in Medway it's younger people that we need to focus on. And that was really surprising for our stakeholders in the room to know that actually they need to focus on younger population. When we drilled down a bit to understand who these patients were, and when we went into like cohorting, we've actually discovered that it was actually fit patients who used a lot of resources in unplanned care. So these very same patients who could really well use planned care were using a lot of unplanned care via A&E mostly. So we had a good idea on whom we had to focus on. And then we needed to have an idea of a way forward, and we looked at operational data to understand what can we do to reduce these emergency admissions and what can we do to reduce lengths of stay. And that's where we looked at alternative services, mostly in community, to see how we can then make these patients being taken care of in a better care settings. So that was the operational aspect of how we can get better. At GP practice level, it was really interesting. So the real strength of the ACG approach is that all of this is case mix adjusted. Because usually when we use benchmark, we always have the challenge that, yeah, but my patients are slightly different. In this case, we have case mix adjusted all of our benchmarking and comparison. And what we found is that if all GP practices were aligning their performance to the upper quartile, we could get to the system sustainability. So it is challenging, like saying that all GP practices have to raise up to the upper quartile is challenging, but at the same time, it's realistic because it's just the neighboring practice. We're not talking about some conceptual benchmark. We're talking about actual GP practices who take care of the same patients in this exact same area. And again, one of the big levers is that we were able to say who these patients were, not name them, even if we can relate back to the GP database if they want to re-identify the patients. But we knew where those patients lived. Obviously, it happened to be in the most deprived area. We knew what those patients' needs were, and we had a way forward on how to take care of them. One of the great wins of this project was that we got the stakeholder to agree on a common narrative. So we used this concept of a vicious circle to show that actually this trust deficit that we're all trying to tackle is a bigger problem. It's a problem of how do we take better care of our population, and that ends up into a deficit. So there is external pressure that makes people use too much unplanned care, go to A&E too often, and the internal pressures where the trust can get better, can discharge patient earlier, and can solve blockages within the trust. And that was really the great win, is that at the end of this project, our stakeholders really agreed on that vision, really agreed that this was the right diagnostic for today's state, and this was the great starting point for tomorrow's future state. So we got them to an agreed view of the demand capacity and finance baseline and the likely 10-year projection of the system. We had a shared narrative with all stakeholders that was based both on stakeholder interviews and data analysis. And most importantly, we had a group of stakeholders who kept looking backwards at who did wrong things, who had the wrong data, who did describe accurately patients' demand. And we changed that dynamics to have a group of stakeholders looking forward, having a very clear and concrete group of patients to focus on, having a clear route to take on new services to develop, how to change patterns of use in care, and that was really a great win of this project.
So in Medway we have essentially moved them to the point where they are at the point of redesign. In Wandsworth, we came in a year into the implementation of their Planning All Care Together programme. At that point in time, there was also a redesign going on in community care and significant amount of service redesign at the kind of overlap end of social care that came under the BCF or various other names which it had across the course of time. And so the real challenge was that it's a system with a lot of moving parts. It's a system with a lot of changes being made. And actually, how on earth do you project what those changes are going to do, what the impact they're going to have on services is? How do you project what the outcomes you're expecting to achieve for patients are? And then how on earth do you measure it? So that was fundamentally the challenge that we picked up in Wandsworth. So the approach to meeting the challenge, I'm not going to dwell on this in too much detail, but fundamentally it was back to that triangulation of engagement with the stakeholders, of operational and clinical data, and in this instance, because we were 5 years ago and at the beginning of the journey for integrating care, the separate evidence, case study evidence, much of which was international, and bringing those things together. Essentially, it was a 12 to 16 week programme to develop the prototype for the evaluation tools and reporting, but 3 years of light touch support in order to actually help get that established and working with the CCG. So our approach to setting targets and understanding what was going to happen was very much around switching the logic from looking at what is going to be done to very much looking at who it is that is going to be affected, and defining cohorts that were going to be touched by the different service interventions, and understanding the targets based on a very rigorous process of benefits mapping. And this benefits mapping process was a tool by which we essentially said, look, if you're going to measure outcomes successfully, actually you've got to spend a bit more time planning them. You've got to really understand what your logic of benefit is. How is it that the thing you're going to do is going to change the thing that changes something that actually has the impact on the patient? And if you get to somewhere where there's a cloud and you can't draw a line that explains how it's happening, then you can't measure it. So that benefits mapping process was critical to being able to actually make the evaluation work, but it was also a very powerful tool for drawing clinicians from across the community and primary care and care professionals from social care together and developing a common language of benefit as to how all the things they were doing actually come together to impact service users or patients or populations or whichever version of the word we were looking for. So the approach to evaluating the programme that came out of this was fundamentally we are going to make a set of macro level changes, what you might call system level interventions. Most of those involve spending money at some point in time, and they are to achieve milestones on a programme. So the first thing that we actually need to do to evaluate the programme is to understand what's been done versus what we planned, and if things haven't been done, then actually what impact we think that's going to have on what we planned. Secondly, then we are planning a set of interventions which result in a quantity of things being done. So we need to put in place measures to establish that we are actually delivering the quantities of things that we said we were going to deliver. And in the case of Wandsworth, we had read codes in place to track the various interventions in primary care corresponding with the elements of their proactive care programme, which included many of the things that have been talked about in the room earlier today. We then had a set of effectiveness measurements. The effectiveness measurements were essentially agreed KPIs that provided leading indicators that said, not only has this thing been done, it's been done in the way that we planned, and so we believe that it is going to have the impact that we planned. And some of that is about the events occurring in the right sequence and with the correct follow-ups. Some of them were around diagnoses and test results coming back within certain patterns. Some of them were around the not showing up in certain places within a given length of time after being touched by community services, for example. Equally, there were measures of staff training, etc. So there were quite a lot of different types of KPIs, all of which came together to say we think we've done things in the right way. All of those, together with the benefits mapping that we did, allowed us to say, actually, we understand benefits as being delivered by a portfolio of interventions for each cohort. So we heard the term cohorts of common need earlier. We had quite a specific definition of a cohort of common need, which is, with respect to the interventions being planned, each cohort of common need has a homogeneous set of interventions. And for that cohort, if they need 6 things, you don't do one of them, they'll still end up in hospital. This one needs 3. If we don't do one of those, they'll still end up in hospital. So actually that meant that through the tracking and effectiveness measurements, we were able to then produce quite a statistically valid expectation for what the impact we were still expecting to get would be. So finally, the final piece of the puzzle comes back to the actuarial nature of the ACGs. So fundamentally, coming up with control groups, particularly in a system like this where everything's moving, is not possible in the standard way, which is here's a set of patients we do something to, here's a set of patients we don't, and we'll test one versus the other, because increasingly the ones you haven't done things to is a dwindling population. It's not like the ones that you have, and in any case there's an ethical issue associated with not doing something for the ones who are not having anything done. Fundamentally, the real key is that actually if you have an actuarially sound view of risk, then post-intervention actual compared with pre-intervention risk is the absolute gold standard of outcome measurement. So sticking all of these things together in a line, we then had a process which essentially drew in a combination of milestone tracking and data analysis in order to come up with a very rigorous understanding of how well outcomes were being delivered. And the final piece was drawing in input from the various stakeholders so that the reporting around that actually communicated insightfully. I'm being told that I'm taking too long. So
the first time I've done it this morning.
So the final piece was putting it together. So essentially, what I've talked about so far is steps 1 to 7 on this, with steps 1 to 3 actually being an inclusive approach to setting up the evaluation. Sticking them together in step 8 is closing the loop. And actually, in terms of the key outcomes we achieved, I'm not going to go through the earlier ones, which are all about the geeky stuff. Really, the key piece was that we established a lasting impact through what's falling off the bottom of the page. That the work began in 2014, 5 years ago when we last spoke to people in Wandsworth. It was still being used. It has been developed past where we left them with it, but actually it continues to provide value.
For more information and insights, visit our website, sollis.co.uk.